A very good morning. Clinical and radiological features of type A aortic dissection, a retrospective observational study and Indian's perspective. So, first we'll talk about what is aortic dissection. Aortic dissection occurs when there is a tear in the inner layer, allowing the blood to enter through the tear and fill up between the inner and the middle layers, causing these layers to separate, or a dissection. So, as you can see, that there is a tear that is occurring in the intimal layer, and then the blood is getting into the middle layer and the inner layer, leading to formation of a false lumen and a true lumen and an aortic dissection. So, clinical presentations of aortic dissection. Most common clinical presentation is pain. The site of the pain is chest pain, back pain, abdominal pain, flank pain, and an extensive or a generalized extensive pain is present. So pain is sudden onset, severe or the worst ever pain, maximal at the time of onset, sharp, tearing, and ripping pain. Rarely it can be painless in old patients or patients with neurological complications. The acute aortic insufficiency and coronary artery compromise will lead to dyspnea or pulmonary edema in such patients. Cardiogenic shock is present in 25% of patients, and cold, clammy extremities are present. Hypotensions may be due to the acute massive aortic insufficiency, tamponade, or coronary artery occlusion. So hypovolemic shock is there. Can be because of aortic rupture. We should be beware of pseudo-hypotension and palpate all 6 pulses, that is bilateral carotids, femorals, and radial artery. Hypertensive crisis may be because of pre-existing hypertension or due to renal artery occlusion or hyperadrenergic response to pain. Neurological complication can also present, like a presence of syncope, stroke, coma, or paraplegia in such patients. Malperfusion syndromes are mainly because of mesenteric ischemia or limb ischemia, present as an acute limb or. So physical findings would be depending upon the organ involvement and complication. Hypotension, wild pulse pressure, or disparity of pulses can be present. Aortic regurgitation, features of pulmonary edema, cardiac tamponade features that can increase jugular venous pressure, muffled heart sound, or a pulse deficit may be present. Limb ischemia presenting as acute limb ischemia, shock, features of shock, abdominal findings, and then neurological findings such as a confused or agitated patient or paraplegia presentation. Myocardial ischemia can be present, and it would be difficult to differentiate from an acute myocardial ischemia or a acute coronary artery syndrome. So, what are the patient characteristics? In type A dissection, it would be a young patient presenting with a connective tissue disorder. In acute coronary syndrome, it would be an old patient, hypertensive patient, dyslipidemic patient, and angina pectoralis may be present. Pain characteristics would be in type A dissection, sharp, excruciating pain, well localized, and typical propagation. In acute coronary syndrome, it would be heaviness or crushing pain, vague in nature, and radiation of pain. On physical examination in type A dissection, it may present with pulse deficit, differential blood pressure, pied pulse pressure, murmur of AR, muffled heart sounds, and malperfusion like mesenteric or an acute limb ischemia. So now the investigations that are there are done to confirm the diagnosis of an acute dissection, if it is present or not. Then we have to see if the ascending aorta involvement is there or not. If it is there, then it is a type A dissection according to Stanford's classification, or else it would be a type B dissection. Then we look for the site of proximal intimal tear, the extent of the dissection, the diameter of the aorta, involvements of the coronary ostia, arch vessels, and visceral arteries, pericardial effusion, left ventricular function, and the valve function. For the workup, we look for a detailed morphology of the whole of the aorta, presence of aneurysm, the morphology and complications like the presence of any thrombus, ulcer, or dissection that is usually present, the arch vessels, the vertebrals, the carotid and the subclavians, the renals and the iliofemoral arteries, the structural imaging versus functional imaging. So for structural imaging, we look for the whole of the aorta, the aortic dimensions at different level, aortic branches, the origin, the course, the patency, coronary anatomy, coronary artery disease presence, the left ventricular outflow tract, chambers, the left ventricular wall thickness, and the mass effect, if it is there, onto the airway and the esophagus, CT angio. These are the different levels of the CT angio. As we can see, at number 1 is the aortic, usually at the aortic annulus, then the aortic root, then the STJ junction, sinotubular junction, ascending aorta, and then there is the arch at different levels, the descending thoracic aorta at the level of the diaphragm, and the abdominal aorta, and the femoral arteries. Aortic diameters can be seen in CT as well as in the echocardiography, with CT imaging being better. As aortic sinuses, we can see at different axial cut, the coronal and the sagittal sections, we can see sinus diameter. CT angio imaging looks at the location and the extent of the flap. They look for the dissection flap. The maximum aortic diameter is seen. Thrombus, calcification, which is usually seen only on CT. The rupture and the iliofemoral diameter, if it is present. So CT for proximal aorta, how is it different? Usually it is an ECG gated and breath holding is seen. Thin slice acquisition less than 1 mm. Whole aorta, when we do, the ascending aorta is usually gated and the abdominal aorta is usually not. So what is ECG gating? ECG gating is the acquisition of images at the time when the heart is most quiescent, which is usually the mid diastole and end systole. Hence, the least motion artifacts in these phases are seen. If ECG gating is not seen, as a non-gated scan here, we can see that there is the presence of pseudo dissection is seen. Actually, there is no dissection, but due to non-ECG gated images, the dissection is seen in these findings. Images. In echocardiography, we look for the aortic valve morphology, cusps, function, and mechanism of the aortic regurgitation. On the aortic root, we look for the aortic annulus, the virtual aortic annulus, which is seen on echocardiography, the sinuses, the sinotubular junction, proximal, ascending aorta, and echo are seen. The left ventricular outflow tract, the systolic function, the diastolic function, and most important, the pericardial correction or tamponade, if it is present, is seen. The tests that we discussed earlier was the pulmonary function test, use spirometry, the duplex ultrasonography of the various blood vessels, the carotid, radial, the femoral are seen, and the indirect laryngoscopy, the renal function test, the liver function test, the coagulation profile, viral markers for surgery. So our experience is we did a study of clinical and radiological features of type A aortic dissection. So as the literature lacks report from Indian subcontinent, the present study was undertaken to understand Indian scenario at initial presentation of type A aortic dissection. So our record was of 162 patients which we operated from June 2014 to June 2019, and of these patients. So initially we found that the mean age was 43.3 plus minus 13.5 years, and 131 patients were male out of the 168 patients. 146 patients had an acute and 16 had a chronic type A aortic dissection. 1/3 of the patients reported with the 24 hours of onset of pain. 45.6% of patients between 2 days to 14 days, and 11.1 patients reported after 14 days. The chest radiography showed a mediastinal widening in 88.8% of patients. The transthoracic echocardiogram identified dissection flap in 81.4% of patients, and severe aortic regurgitation was present in 65.2% 2% of patients. The mean aortic diameter was 50.6 plus minus 11 mm. So